Good afternoon, everyone. Thank you so much for joining us. My name is Amanda Perez, and I know most of you have seen emails from me by now. I'm a research assistant at the Center on Brain Injury Research and Training here at the University of Oregon. And we are so grateful that you've joined us for this series. So Lori Powell is going to be doing an introduction here shortly. And this is on that Eastern Oregon Brain Injury Resources Winter Webinar Series. My role here is just to give you a couple of the background pieces, mostly kind of the technological pieces behind it. So in orienting you to this webinar, if you look at the bottom of your screen, you should be able to see chat and Q&A. That's going to be the main way that we're going to be interacting with you, since you're not going to be able to talk with us in this webinar platform, but we really want to hear from you. So as we're going along, as you have questions for Lori or Jana or Kent or Derek, please use the chat or the Q&A to write in your thoughts, comments, questions as we go, because we want to make sure that we save them to ask those questions as we get to that part of the session. We are going to save questions till the very end, so that everybody has a chance to get through their talk. And if we've already addressed those questions, we'll come back and review them as we have time towards the end. Things to keep in mind if you do run into any tech issues, please let me know via chat or via email. My email is Perez, P-E-R-E-Z-A @cbirt.org. Or you can just respond to one of the emails that I sent to you. I will be monitoring that throughout. And this is recorded. So if for some reason you have to pop out to go handle an issue with work, I know several of you are active practitioners, this is going to be recorded and we will post that later. So with all of that said, Lori, I'm going to turn this over to you.
Thank you, Amanda. Welcome, everyone. This is webinar number 2 in a 3-part series. And today we're focusing on who serves and how to serve persons with brain injury. And this work is being supported in part by the Oregon Administration for Community Living TBI Partnership Grant. Hey, again, my name is Lori Powell. I work for the Center on Brain Injury Research and Training at the University of Oregon. And I'm so grateful to be joined today with members of our Eastern Oregon Brain Injury Resource Network, Dr. Derek Earle of Family Health Associates of Hermiston, Oregon, and Jana Mitchell, community health worker with Lifeways serving Umatilla County. And we are also joined by Kent Gross, operations manager for Lane Independent Living Alliance here in Eugene, who is both a provider and has lived experience with brain injury. So welcome to our panel. In terms of an outline, I'm going to provide just a brief overview of what was covered in the November 4th introductory webinar. And then per request of those participants, I'm going to give a very brief introduction to screening for and accommodating brain injury. And those topics will be picked up by Derek and Jana in their presentation about being providers in Eastern Oregon serving this population, and then Kent will fill it out with giving that shared perspective of being a provider and living with a brain injury. And as Amanda said, we'll do Q&A at the end. So that's just a brief overview of what we're going to cover, but let's do an introductory poll right now to find out a little bit more about all of you that have joined us today. And I think Amanda has it up there on the screen for you, so thanks for taking the time to fill out these 3 questions. Did you attend webinar number 1 in the series? Number 2, what's your background? And number 3, if you work with people with brain injury. So thanks for taking a moment to do that.
And thank you so much for answering that so quickly. I can see that we are right about 3/4 of people. Give it just another few seconds here, so you guys can put in your answers if you haven't done so already. Okay, so I'm going to go ahead and share that out so you can see that.
Okay, great. We have a really nice breakdown of people returning to the series from webinar 1 and some new participants. We're glad you're here for the second in the series. The majority of you are providers, but we do have some people with lived experience with brain injury joining us today, and others as well. And a pretty large percentage saying that you do have experience working with brain injury. So it's good to know what your background is in that regard as well. So thank you for that input. And Amanda, feel free to go ahead and close the poll. Okay, so let's just go back in time to the why this webinar series in the first place. Originally, this was going to be a series of town halls in person in Eastern Oregon. And when COVID hit, we had to pivot our planning to this platform. But regardless of the platform, the goal has always been to sort of think about the wide range of providers that are serving people with brain injury. And this is our kind of our guiding statement. You may not be a trained brain injury provider, but you probably serve people with brain injury, whether you know it or not. And we covered in our last session the different groups of people that are at risk for brain injury, depending on age, occupational status, types of work that can put one at risk, sports related activities, life situations, and so forth. So this webinar series is really meant to be just to raise awareness, provide some education, some resources, and connection. So a little bit more about what we covered in November 4th. I provided a very brief introduction to brain injury, including basic definitions, causes, symptoms, life impacts, and so forth. Then Kurt Toombs, the executive director of the Eastern Oregon Center for Independent Living, provided an overview of the consumer-directed services provided at the EOSIL, and then honed in on the screening process they have, screening for brain injury that they've integrated into their intake. We're going to touch on that a little bit later here in a minute. Then David Kratky, Oregon's Brain Injury Advocate Coordinator, shared some information about legislative initiatives that he is spearheading to improve access to services statewide for people living with brain injury. And then we asked for your input on future webinars, and screening for brain injury came out as a preferred topic. So let's take a brief look at that right now. Why is it important to screen for brain injury if there's not an already clear documented history of brain injury in the record? Well, providers may be working with someone with a brain injury that is not as unknown for any one of a number of reasons, including the fact that maybe medical documentation has been lost, particularly if an injury was sustained in childhood. Maybe it was never documented in the first place. And this is one piece of legislation that Dave is working on right now, is to look at how to code for brain injury that with documentation that will stay with the person throughout their course. We also know that brain injury doesn't always show up, often doesn't show up, especially if it's mild, on imaging studies. And so it can get lost in the shuffle without that hard evidence. And then it can really affect the services being provided. If somebody's struggling with memory and attention, it may be difficult to follow through on treatment plans. So lots of reasons to screen for brain injury. The method we're going to look at right here is the Ohio State University TBID method. This is a widely used, reliable, valid, and free tool that you can use to screen for a lifetime history of brain injury. It's very short. It's a structured interview with an individual. It uses familiar wording and terminology. It focuses on injuries, more TBIs, traumatic injuries caused by a blow to the head striking an object, and so forth. But there's an adapted version for other types of brain injuries, such as anoxic brain injuries. And the links that you see there at the bottom of the slide can get you more information and training support concerning the use of this method. Here is a screenshot of what it looks like. And I'd like to draw your attention to the column on the left, the 5 key questions that are asked, and it's a tiny print, so I'm not going to read it to you, but just to kind of draw out one of those questions in your lifetime. Number 1, have you ever been hospitalized or treated in an emergency room following an injury to your head or neck? Notice it doesn't say brain, it says head or neck, because that can be more obvious to an individual if they're trying to remember, maybe, if there's a history there. And think about childhood injuries as well. So let's now take a look at how Kurt Toombs and staff at EOSILS adapted the OSU TBID method for their intake process. I mentioned earlier, Kurt shared this slide with us in our first webinar. And again, just lots of print here, but just to draw your attention to the second column from the left. And there you'll see with the copies of the slides that you have, you can see how they've unpacked and modified the OSU TBI questions, stretched them out a little bit, and then went forward with adding columns for behavior impacts and impacts on everyday functioning. And like I said, they are using this as a part of their intake process, which is great. What we have here in these next two slides is another adaptation of the OSU TBID method, really geared more towards individuals who themselves could maybe identify a potential history of brain injury. This is a 3-page panel brochure that was developed as part of our Eastern Oregon Brain Injury Network. And here's like the front end of the panel. And I want to draw your attention to the providers that are listed there. This is the one for Umatilla County. And you see the EOSILs mentioned at the top for further information to get some help. CAPEGO, Dr. Earl is mentioned there, as well as Sunshine Mason, Veteran Services Coordinator. And then here you see those 5 questions from the OSU screener, along with symptoms that can often come with brain injury. So just to take a step back, those are just, just in a nutshell, an excellent screening tool that can be modified and used and integrated into a program. But then let's move on to the next question real quick. What happens if somebody screens positive? What do I do? So this flow chart helps a little bit to explain what the next steps could look like. So we have a person who's screened for an ABI, acquired brain injury. If they screen positive, then a provider might think about 3 directions to head. First and foremost, there could be some very simple strategies and accommodations you can use as a provider to make life so much easier for the person with the brain injury and negotiate those strategies with them. We'll look at some of those in just a bit. Supplemental resources. In webinar number 1, we sent out 3 informational sheets. One included, for example, the Rehab Hospital of Indiana fact sheets on brain injury, tailored to the needs of persons with a brain injury, that can be very helpful educational tools to learn more about what the person is experiencing. It kind of normalizes it a little bit. And then, of course, referrals. Where else can I help refer this person to get more support? And here are some examples of accommodations. Very common, easy to use, quiet, distraction-free environments, for example, using text messages or phone calls for appointment reminders if someone's struggling to follow through and remember their appointments. So I'm going to stop there. That was quite a run through screening and accommodations. We have more materials for you, but just wanted to address that piece. And now it is my pleasure to introduce you to Dr. Derek Earl, who will tell us a little more about his work in this area. So I'm going to move the slides forward and let Dr. Earl take over.
Thank you. Can you hear me okay?
Mm-hmm.
Perfect. So my name is Derek Earl. I'm a family physician in Hermiston, Oregon. I also, as part of my clinic, do a concussion clinic. And I want to start by telling you a little bit about my experience, but then also about a couple of specific patients. I was a college athlete. I went to medical school. I went on to family practice residency, moved to my wife's hometown, and some opportunities became available to start doing sports medicine for local schools. And over time, that grew into a network where I've done up to 12 schools. I now am the team physician for 9 schools in the area. I also am the team physician for Blue Mountain Community College and for Tri-Cities American Hockey Team. And a lot of it because a number of years ago, when I was working with one of the schools, we felt the need to become more robust in our concussion care. Several years ago, I want to say 2017, I was visiting with my team here at my clinic, a small 1A school, and we were doing some baseline concussion, computerized neurocognitive testing for them. And we were doing some education for their coaches and their staff. I was approached after the meeting by one of the teachers who asked to talk to me for a minute. And in the hallway, he said, I need you to take a look at my son. And he proceeded to tell me about his 25, 26-year-old son who had suffered a concussion and he wanted him to be seen. Well, the next week had the privilege of meeting a young man that we'll call George, which isn't his real name. He had been a 4.0 engineering student at one of the universities in Oregon, had finished at the end of his junior year a internship at Boeing and was looking at graduating and joining Boeing for a job. He had put off his PE classes until his senior year, wanting to focus on engineering. And in his first semester of his senior year of school, he was struck in the head by a basketball and started shortly thereafter having headaches. By the end of the semester, he was unable to focus, couldn't remember his work, and had flunked out of school. And for the next year and a half, he would return to the small farming community where he grew up. And the most he could do for himself was to get out of bed some days, put on a backpack of weed spray, and walk up and down canyons near the family farm, spraying weeds. And he and his family were very frustrated. So we offered to do what we could to help him. And it became really apparent quickly that he had a lot of needs that we weren't able to address in our local community, which required us to start looking even further outside than what we normally did for our concussion patients. And that opened the door to dealing with more than concussion patients and with other traumatic brain injury patients. If you could go to the next slide for me. In the last several years, our concussion practice has grown to include a lot more than concussions. When we deal with concussions, this is kind of our goal, and we were frank and forward with our patients when they walk in to see us. And that is, we start by with the goal of returning to their life before their concussion and their injury. If we have anything that hinders a recovery, we try to quickly identify it and adjust for it. And if you could go to my next slide, Lori. So we've taken this philosophy and we've moved it towards our other TBI patients. And what we've come up with as a practice is this goal. Our goal is to help patients achieve their highest possible level of function and their best quality of life. And then we feel there's three main things we can do. First is identifying individual needs, including pathologies and barriers to their improvement. The second is finding ways to help them maximize their ability to function both at home and in the community. And then third, optimizing treatment of both mental and physical conditions, including those caused by TBI and not caused by TBI. And we've often found that a number of medical conditions are either not taken care of by previous providers because they've been focusing on the TBI, or they have been neglected by the patients because of complications of their TBI. If you can move to the next slide. And then just kind of a basic review. I mean, and any of you who have experienced or dealt with patients with TBIs, you know that symptoms can range dramatically, and there's different areas of symptoms. And this is kind of a good diagram. You can have physical symptoms like the headaches and the fatigue. You can have behavioral symptoms, emotional symptoms, and the cognitive or communication symptoms. You go to the next slide. And so for me, I trained and look at these as clinical trajectories based off of their symptoms. And the path we take with our patients is determined by the symptoms that they exhibit. We don't feel at our practice that we can adequately care for each patient unless we can sit down, identify the symptoms, and also identify what they expect and what their ultimate goals are, and then try to help sort out what barriers they have to improvement. All right, if you could go to the next slide. It's very apparent, it was very apparent very early, even dealing with concussions, that a family doc in Hermiston, Oregon was not going to be able to take care of all of the issues our patients have. And so we run off of the philosophy that it takes a village to help somebody with a brain injury, whether it be mild or it be more extensive. And so there's a number of people that have to be involved in the care. And if you base it off of the category of symptoms, there's a list of some of the people. Can you go to my next slide? So our practice has had to develop a network, and it started with developing a network of providers to help with our concussion patients, and we've expanded it as we began to provide care for other patients. And these are some of who we utilize from our office in Hermiston. You know, when neurosurgery is necessary, we've ranged everywhere from Portland to Spokane and tend to get good care. Neurology is a little bit more difficult because a lot of our area neurologists want to defer concussion patients, at least, if not other brain injured patients. And often we end up relying heavily on getting patients into Portland if they have neurology needs. Neuropsychology, we've worked hard to develop a network of neuropsychologists. Physiatrists, we were lucky and we had a physiatrist in Hermiston who took a job elsewhere over the summer. And so now we've begun to lean on our partners outside of our immediate area. We've developed close relationships with a number of mental health providers, including Lifeways. Neuro-optometrists and vision therapists have been integral in caring for our patients. And these are names of some of these, the providers that help us care for our patients. You could go to the next slide. This includes our therapists. Therapists become a very important part in the care of a number of our patients, from physical therapy to vestibular therapy, vision therapy. We've been lucky now that we have local cognitive rehabilitative therapy, where we didn't until recently. Most of our patients were going either into Portland or some up to Tri-Cities, Tri-Cities, Washington area. The one thing I would say too is, when you're lucky enough to be in a community with a good athletic trainer, for school students or college students, it's great, but they aren't readily available beyond that. One of the things I want to point out with the team that we've developed, or the network we've developed, is another patient. Over the summer, I was privileged to have a young 45-year-old gentleman move home from back east. He, in 2017, had been working at a federal government job. He was at the top of what he considered his profession at the time. He was at a party and he fell backwards off a balcony and suffered a TBI. He was initially diagnosed with a concussion and thought he'd recover fairly quickly. By the time he moved home 3 years later, he was having chronic headaches. He had significant cognitive deficits that resulted in his not being able to continue to work. He had motor dysfunctions that had never resolved. And he walked into one of our 2 small clinics and sat and began talking to me. And the first question he asked is, why is a family doctor dealing with my head injury here? He was used to and had been part of a TBI team in the Washington, D.C. area, where his care was coordinated by a neurologist and a physiatrist. He had a number of therapists involved, had a neurosurgeon involved, had psychiatry involved, and they were all under the same roof. The good news for us is, over the last several months, he's reassured me several times that he gets the same care. He just has to travel a little bit for it. And we've appreciated that he feels he gets the same quality of care. If you could go to my next slide. Who else serves? Because it's more than just the medical professionals that serve our TBI patients. It starts with the people closest to them. And anybody who has helped take care of a family member or a friend with a traumatic brain injury knows that they end up being the first line often. And this goes out to support groups and religious groups, and community health workers. And at the end, like I said, and many others, because I'm never amazed, I never cease to be amazed at who's willing to step up and who's able to help one of these patients for us. Next slide, please. So we realized really quickly in our practice that there's a limit to where medicine can help take our patients. And it's because of the siloed approach of medicine. I think in traditional medicine, even primary care, we often fell in mental health. And there's been barriers there. We fell in where addiction and substance abuse treatment comes into play. And then even more importantly, because there is some relationship there, what I didn't realize until more recently is how much need the patients have in what we call community reentry treatment and engagement of community resources. And there's so many things that some of these patients need, such as the social interaction skills, the ability to just simply set goals. Sometimes that's all we do in a visit in our office, is help them set goals. Financial management skills, safety at home and in the community, vocational training, transportation, and anything that allows them any independence. Medicine's not really well equipped at dealing with this. We're much better equipped at sitting in an office, talking to them and telling them to go seek out resources. My next slide. So with the experiences with this group, and especially with Jana, who you'll meet next, I've gained a new appreciation. In concussion management, I've always followed this model where the patient, their family, and friends are at the center. And as we're trying to return them to their sports and their school, there's a medical team, which includes often physician, therapists, and an athletic trainer, an athletic team, which is their coaches and their athletic director, and an academic team, which is their teachers and counselors. If you could go to the next slide. In our practice, we've modified this change it a little bit, where there's a medical team that still includes the providers, including myself and the therapists we use. There's a mental health team because a number, if not most of these patients require some sort of mental health, but they aren't successful in optimizing their recovery and reaching their highest level of function without a team there for their social and community support. And at that point in time, I think I'd like to turn the time over now to Jana.
Hi there, I'm Jana Mitchell. I work at Lifeways and I'm a community health worker. And generally I provide community services for individuals who have both mental health and physical health conditions. And this is done in coordination with one or more of Lifeways providers, medical providers for medication management, or a counselor. Once an individual is referred to me, I have basic health and medical intake is done. It's like a checklist. And it asks about, those typical things that you would expect. Do you have diabetes, high blood pressure, asthma, high cholesterol, and all of that. And then it would have that blank line that would say, and any other health condition. And most of the individuals that I work with have nothing to put in there. So I put forth the question specifically of have you had a traumatic brain injury? And out of that, it has turned out 40, 50, 60% of my clients have had a traumatic brain injury or can recount specific situations that would indicate a potential for a traumatic brain injury. And along with that, many of them report symptoms related to a TBI. What's nice is for me to have in hand the brochure that we've talked about, and we can just go through and say, ask those 5 questions, and then also discuss what those symptoms would look like. I'm at a position, and I think a lot of other individuals who are not those primary medical providers, at actually having the opportunity, if we're aware, to identify those individuals who need services, who have no idea that they actually have had a traumatic brain injury or that it's important enough to bring up with their primary care doctor. So after we've determined that there's a great potential for having a traumatic brain injury, we would then refer. And in Umatilla County, that means Dr. Earl. And once we go in, we'll make an appointment. And then before that appointment, the individual and I will sit down and we will do a medical and a treatment history. Individuals oftentimes have not considered that they've had a traumatic brain injury, or once we've made the appointment, we'll go ahead with the other, with the client, and we'll make a health and treatment history. We'll also just look at life history and events that could have been a situation that a traumatic brain injury had occurred. Once we get that done, we'll take that to the doctor's appointment, Dr. Earl, and we'll share that with them and be able to create a complete and full history. After that appointment, once it's determined that they do have a traumatic brain injury and that there are specific things that need to be addressed, there will be lots of referrals. And individuals who have had a traumatic brain injury are oftentimes overwhelmed by first the information that they have a traumatic brain injury that they didn't know, but then also all of the work and assessment that is going to have to take place. So at that point, I work and coordinate with the doctor's offices, the referral individuals, and just supportive and making sure they get to appointments, reminding them, sometimes taking people to appointments. So the reason why I have kind of shared in detail all of these things is what I do is something that a friend or a family member can also do. They can take that assessment, that 5-question Ohio assessment, and share it with a friend or a family member who you may suspect has had a traumatic brain injury. They can certainly take them to their primary care doctor. If you have the resource of Dr. Earl, set up that appointment. And then it would be important for you to help them by creating that timeline and treatment history and the list of the doctors that they've seen. Write it down, make a checklist, take it with you to that appointment, and then offer help to assist with the follow-up and scheduling of appointments. I think now you're just showing the brochure, is that correct?
Yeah.
Okay, and these are the 5 questions that we refer to, and you can elaborate on them, which is essentially what it looks like the EOCIL has done to ask more detailed and specific questions. But as I'm doing a medical history, I kind of get an idea of where someone's been and what their situation is now. It's nice for them to see that, and I think it's a very important tool. I've had individuals that pick it up and say, I didn't know, this is me. What do I do now? And so that allows, that identification of an individual who needs services. So I'll go ahead and send it back.
Thank you, Jana.
Mm-hmm.
It looks like Kent, you're going to be up next if you'd like to share your camera and unmute.
There we are, everyone. Kent here with Lane Independent Living Alliance, Eugene. I am coming into this from 2 sides, actually. First of which, I work as an operations manager for a nonprofit of independent living that works with those with mental and physical disabilities. And then also, too, with the latter part, and I'll be spending my time wrapping up my time with you all today, is I have had a traumatic brain injury. And I've also had a brain injury and a stroke, and I'll be talking more about that. But let me kind of get into the work at Lane Independent Living Alliance, LILA. Working with those folks who need to get from where they are to where they want and need to be. That says a lot when you're trying to deal with a traumatic brain injury. Within our agency, what we are doing is we're working with folks who have the need from a traumatic brain injury, and how we help them is just working through independent living skills trainings, such as learning how to ride public transportation. Sounds easy enough, doesn't it? Well, if you're like myself and a number of the folks that we help, not so much. What we do is we have a good working relationship with Lane Transit Center, Eugene. And what they do, and we help along the way as requested, we help those folks learn how to ride the bus, how to remember where to get off their stop, how to sit and find ways that's not overstimulating for them and anxiousness and worry and ruminating and running around with their hair on fire, for lack of a better word. So we're helping through those kinds of things, and that's helpful. Another example of how we help is with assisted technology. Again, this is important because when you're dealing with a traumatic brain injury, the folks that we're serving, and certainly those who've gone through it, like myself, you can use devices such as a voice recorder. That is a real good tool. That helps to be able to remember a type of a grocery list, let's say. I need peanut butter, I need milk, I need eggs, and I need some soda. Well, if you're like me and some of the folks that we see, that might be somewhat troubling when you're going to a market or some place like that, or a fast food place. Wow, I've already lost my list. I've already forgotten my list. And I came and I say, I came, I saw, and I went, and I kind of went with, Twinkies and a soda and God knows what else. None of the things on my list. So that's important to help those folks learn how to keep their appointments in a shopping sense, and also to working with their health providers. And then just one other thing when it comes to independent living skills, and that's working as a disability claims specialist. One of those is the things that I do, helping folks who've had a traumatic brain injury, who's had a stroke, who's had an injury that is struggling. They're not able to work for obvious reasons because of their injury. And then working with the Social Security Administration and working on all levels of that. And what I mean by that is initial application, appeal, that happens a lot, and then reconsideration, considering the appeal, and then taking it up to the administrative law judge hearing level. And I'll be talking a little bit more about that and how I and others and Lila have worked through that. And then peer-to-peer counseling. This is a big one. Kind of speaks on its own when I say peer-to-peer. Kind of been there, done that. What we do at Lila, we have staff who have the person come in, they sit back to relax, and they tell their story. What a better place to start, right? You're hearing and you're meeting that person where they're at. No assumptions are made. Well, Jay, Sally, you kind of seem like you're having some problems tracking here. Are we on the same page? Of course, you're not going to approach it that way. Who would? That's ridiculous. What you do is you say, well, I sense that you're having some difficulty from what you've told me in your socializing with your friends and your peers. Let's talk about that. Just unpacking and meeting the person where they're at. And then once you've kind of done that, you've kind of made some kind of report with them, whether it's 1 or 2 or 3 meetings, depending upon where the relationship goes and their needs, obviously. You begin to formulate goals. Who are we going to send out an information and referral for this person? Is it going to be back to some type of pathologist for some speech recognition and different parts with that? Is it going to be someone to help them through their balancing issues? Not being able to walk down a hall, not able to take stairs, all those things become problems, all those things become annoyances, and all of those things are parts of goals that we set for each one of those folks as they ask for them. And then I just want to talk a little bit about different ways that we help them move through that to help them feel more comfortable, more at ease. Music therapy. We don't have a music therapist on staff, obviously, just because of our size and that kind of thing. But we certainly do encourage them to use different apps, to use that, and just be able to use that to defray different times when they're feeling nervous, anxious, or just can't process. And then being able to use headsets to kind of channel out other noise and annoyances. And then I kind of just want to just really get into something more transparent and more personal here with all of you. Personal experience. I've had a traumatic brain injury, and I've also had a stroke. I had a traumatic brain injury when I had a head-on collision at highway speeds while I was living in Eastern Oregon. And at that time, that changed my world, as you can quite imagine. I was rushed and whirled by ambulance into St. Anthony's Hospital, Pendleton. And I spent some time there and kind of worked through some of the things and figuring out how was I going to start to rebuild and work through life. How was I going to begin to learn how to balance and walk, kind of like down the hall I talked about just a minute ago. How to be able to formulate sentences and talk and discern as to what's being said around me. all those things became tough. And it's tough for the folks that we serve, and as it is for many of those others on this panel here. And then as time kind of gone on, I was living in Pendleton and going to school in Hermiston and helping with some of the high school people there. And then I ended up getting back to Blue Mountain Community College, where I started working with some of the folks at the community college with this, what they called a program called Brain Train. And it was interesting. It helped me kind of get some cognitive bearings. It helped me kind of formulate and process. And then working with a speech pathologist, that was key for me. Being able to actually speak and be able to try to formulate words that I once couldn't do. So I have to say, the types of programs that are out there that's been mentioned, the persons that have been mentioned and has spoke here today, there's a lot of good resource, and there's a lot of good findings, a lot of many surveys and testings to try to figure out how to best help someone. And I would just encourage you to reach out to any one of those persons and use your resources. And then last, I just want to say, coming from a rural community such as Eastern Oregon, some of the towns that I mentioned, Pendleton, Hermiston, LeGrand, it's all about information and wanting to know to get those informations. There's a lot of people I've known for over the years. They have a family member, or even them themselves have received a traumatic brain injury, and they just don't know where to start, and they try to blow it off, for lack of a better word. Oh, I can tough this up, I can do this. Just a short little story I'll end with this one. I once knew this guy. I'll call him Rodeo Roy. It works. It's not his real name, obviously, but it works. It's a catchy way to remember. And he had this vision and this idea. He wanted to continue to ride the rodeo, bull riding. And his big dream in life at that time was to ride the Pendleton Roundup. That's a pretty good. It's a pretty good goal to set. I mean, that's no slouch rodeo for those who follow. But here's the deal: Roy never made it to Pendleton Roundup. Roy ended up having a real bad wreck, as they call it, on a bull, and he ended up getting a real bad head injury. And Roy just didn't have it in him after that, and he just wasn't able to get those services that he once needed. He wasn't able to discern where to begin. Some of his folks around him tried to help provide his family, but it just never was the same. That's a travesty, and that's unfortunate, and that's sad, because Roy was never able to work again. Literally unable to work, unable to ride the Pendleton Roundup. No longer ride bulls. It was a game changer, and I would hate to see any of those kinds of things happen to any one of those that any of you on this call are serving and helping. I would encourage each one of you here today, here now, roll up sleeves and hit the ground running and help those who suffer from traumatic brain injury. And I thank you for your time.
Kent, thank you so much. I so appreciate you taking the time to go through that and sharing your personal stories. Lori, this would be a good time to check in to see if we're ready for some questions, if you wouldn't mind unmuting and joining.
I think, Amanda, I think you will need to help start my video again.
Let's see, does that give you a prompt?
Yes, it does. Thank you. And I wonder if we want to bring up the entire panel for questions. Would you be able to do that so we can all be present when you pull them up?
Well, I will send prompts to each of you. so that they can rejoin.
I agree with you. This is an excellent time for questions. And while you bring in the other presenters, Amanda, I just want to say to Kent, to Jana, and to Derek how profoundly appreciative I am of what you've shared today. Themes that are popping out to me certainly have to do with words like coordination, community, support, you know, what you're doing, Jana, by way of providing coordination and support through, like, for example, going to appointments with individuals, because as we've talked about, it can be very difficult to organize and remember appointments and so forth. And I think, Kent, you've really underscored the importance of, like you said, rolling up the sleeves and providing that kind of help, depending on your role as a provider. And then Derek, the wonderful work you're doing, the examples you provided of patients you've served, and with the kind of network you've built up with providers in the area is astounding. So those were some takeaways from me, but I'll stop talking and see how we're doing with bringing up the other panelists, Amanda. Otherwise, I'm happy to field the questions, but it would be good to hear from them directly if the questions are for the others.
Yeah, I see everybody is back online.
Perfect. Oh, there we are. Okay, great.
So they're all there. And Derek, thank you for answering David, but I was wondering if maybe we could talk about that just a little bit here. So David Crockett was asking, how has telemedicine changed your practice, and do you see it playing a role after COVID? Would you mind speaking to that?
Yeah, so yeah, and my answer is I absolutely see it playing a role after COVID. From a primary care standpoint, we had a quick baptism by fire in introducing telemedicine, to where our clinic was luckily, we were only about 50 to 60% of our visits being telehealth visits. I've actually seen 2 TBI patients now in follow-up visits with telehealth, and we're still trying to find out the best way to do that. I don't see this going away. I think it's a tool that's going to be very beneficial in all aspects of medicine. And I hope we figure out how to best use it in our TBI patient population.
Thank you. I'm curious, Jana, is telemedicine kind of part of what you guys do over at Lifeways also?
We do a lot of it. I do better meeting with clients one-on-one. But we do telemed. I think there may be only one med provider in Pendleton, and many of our psychiatrists and other providers are telemed providers that we've actually contracted with. So that is how an individual would access them. They may come in and have that appointment in our office as a telemed appointment, get blood pressure taken, do med check and some other things. So it is used out of necessity for us. Case managers, peer coordinators, all of us do use it. But those are the kind of jobs where one-on-one contact is almost essential.
Thank you. I was curious how that would impact what you do there also. So looks like we have another question coming in. I just want to encourage all of you, as you do have questions, please feel free to put those into the Q&A and the chat as we're going along. So this is a question from Amy Nation. It says, I work with a family who the youth was just diagnosed with a TBI as a very small child. I don't think the family has sought any medical care for it, though. He is now part of the juvenile justice system, but I feel his behaviors are a lot from his TBI and not that he's a criminal. Would you recommend that he see a doctor like Dr. Earl? Are there things that can be done after being diagnosed that would benefit this young man? So kind of an open panel question. What do you guys think?
I'll start my opinion. He should be seen by somebody that has at least some experience. The first things that come as I'm reading through that is, obviously, he probably needs some mental health care if he's not receiving that. He may need a neuropsychological evaluation to help us decide exactly what is from a possible TBI and what other underlying issues are going on. He obviously has something going on. and to get into somewhere where there's a network of providers that have experience would be beneficial.
Great, thank you. Anyone else have thoughts on that to add? Okay.
Well, I was just thinking, Jana, just broadly speaking about what you were describing earlier about how you support individuals who, there's that program with Lifeways that supports individuals in the corrections system. Could you talk a little bit about that just broadly?
Well, and it is for adults. It's called jail diversion. And just generally, these individuals have mental health components, but we find many of the individuals that come to us through jail diversion also have a traumatic brain injury, whether it preceded going into jail or they actually, because of violence in jail, have received or have a traumatic brain injury. They're supported with that kind of wraparound support, reintroduction to community, housing, support getting signed up with a primary care doctor, getting insurance. When you leave jail, you got nothing. Getting the proper doctors, and all of that, helping them get to and from appointments, which may be difficult, especially in a rural area where you can't take a bus necessarily at the time you need to take a bus to get to court appearances and that kind of thing. So it covers a lot of those things for an individual who would have a traumatic brain injury, and fulfills that niche of getting individual support who have mental health and more complicated cases immediately as they leave jail.
Mm-hmm. Thank you, Jana. And it's entirely possible, depending on what resources you have, that an adjudication officer might be able to help out with accessing the neuropsych component so that you can go ahead and get those testing pieces done. Depending on your role with that young person, you very well may be able to go in and request that. I think that would be a great thing to follow up with if you have further questions on that.
Thanks, Amanda.
Yeah, absolutely. I'm not seeing any other questions at the moment. So if any of you are still having pending questions, please feel free to send that our way. Then Lori, I know you have one more poll that you wanted to do.
Sure, but I just had a quick statement before we leave Q&A officially. It'll buy a little time for folks to enter any other questions. And that has to do with stating that screening, just clarifying the obvious, that screening is not a diagnosis. You know, that we've talked a lot about screening here. Just it's an entryway into trying to get further information. So I think it's been touched on, but I just wanted to state that because Derek, as you mentioned with this one young person, you know, the screening alone wouldn't be enough. You'd need to kind of try to get more information, but it can be tricky to get the neuropsych testing. So that was helpful advice you just provided us, Amanda, about one way to do that. But I just wanted to open it up. Derek, do you have any other thoughts about the screening to diagnosis piece that you could offer, particularly when it may not be possible to get imaging studies and neuropsych testing? How do you roll with that?
You know, that's often part of the difficult one. I actually had a patient yesterday who presented out of our county jail, wanted to be evaluated for a TBI, has symptoms, allegedly has head injuries. And we're going to have a hard time getting some of her services arranged for her to help clarify it. What we go off of mainly is, do we have an injury that could adequately explain the symptoms based on a TBI? What other symptoms and findings, and and then we start ruling out other potential pathologies. And that's where it can sometimes get tricky. The patient I mentioned from yesterday, she has a meth issue. She has some other underlying genetic abnormalities that are going to make it challenging. Sometimes that's where it becomes more the art of medicine than the science of medicine for us.
Thank you. It's a really important point. So it's good to make those distinctions, to know what the potential options are. The ruling out process, as you just described, may be one path to have to take. So thank you for that. And Ken, I just wanted you to have a chance to comment on anything we've talked about thus far. And Amanda, I think what I'll do is I'll finish the slides so we can, and then do the poll after that, if that's okay with you.
Yep, absolutely.
Okay, Ken, any final thoughts and about our conversation thus far?
I just like to, excuse me, I just like to say, I encourage all of you who are providers and part of this today to reach out to those with traumatic brain injuries. I've already said that, but I said it again because I think it's really important. And I was really encouraged to hear and learn more about the types of services. I think it's really in keeping with the COVID-19 and just the distancing and things. I think that's important as well. And I'm glad that that was voiced here today. That's all I have.
Absolutely. Thank you. Okay, I'm going to go ahead and finish up then with the slides here, just to know that the resources that have been sent to all of you today includes a self-identification, the OSU TBI brochure template that you can modify with the instructions for your county. And then also we have more resources and trainings on topics of TBI and behavioral health, and also on how to screen and accommodate brain injury. And that flyer was sent with your packet today. Be on the lookout for our Oregon's Brain Injury Needs Assessment Survey for services and supports that will be coming to those of you registered for this webinar. That's to help us try to improve our statewide support network. And our final webinars on February 3rd, which gets us to our final poll before we end, is topics that we can use for this final webinar. So Amanda, please feel free to put up the poll, and then we will wrap up.
Okay, for those of you who are still with us, that poll is now live, and we would really like to hear from you on what you would like to see in the upcoming webinars. Lori, can you remind me when that next webinar is going to be?
Yes, it's February 3rd.
Thank you.
Yes.
So we just have a couple people responding. So while they're doing that, that's okay. They're starting to come in now. I know it takes a moment to read through all of those options too. So it just takes a minute or two to do that. And then for those of you who are wondering, I know later on after this, you're going to have the email addresses in case people have follow-up questions. Okay. Looks like complaint responses have slowed down. So I'm going to go ahead and share out those results so you can take a look.
Okay. Okay, we see pretty strategies for supporting someone with a brain injury is the top candidate. Absolutely, we can start moving further into accommodations and so forth with that suggestion, and take a look at the others as well. So thank you, everyone. To conclude, it's been a joy to be with you all today. And again, such appreciation for Kent, Janet, and Derek for being our key presenters, and for all of you for being here and doing your good work out there. So take care. Hope to see you on February 3rd. Bye-bye.